future of healthcare has arrived. Artificial intelligence and machine learning are transforming the practice of medicine and improving patient outcomes. This is Smarter Healthcare with AI. Conversations with Dr. Hassan Tetteh as he shares insights into the healthcare of tomorrow and how we can help create it today.
Welcome to this episode of Smarter Healthcare with AI. I am very excited today to host my guest, Dr. Brian Lima. Dr. Brian Lima is a cardiac surgeon at Vanderbilt, a healthcare executive, and probably most importantly for the topic of our discussion today, a physician innovator. So Dr. Lima and I have known each other for many years. He's a dear colleague and friend, and we're going to have an exciting conversation today about heart and lung transplant, but more importantly, what innovative and incredibly dynamic novel innovations we have on the horizon, thanks to his brilliant mind. So Dr. Lima, let's just get right into it.
Sure.
Cardiac surgeon.
Yes.
Tell us a little bit about that. What's your career been like in cardiac surgery? Where did it all start?
Well, it's been a long and winding road, but a lot of fun. I really found my passion in cardiac surgery in the arena of heart transplant, heart failure. It's just such a transformative experience for both the patient and I feel as a surgeon doing those cases, it just never gets old. It's really a miracle every time. And there's so much, I would have to say I'm biased, of course, but there's so much fast-paced innovation happening in that niche area of the grander sort of category of cardiac surgery, which we'll get into. But
Right.
it's just really, I think at this moment, we're just scratching the surface with the potential of the more lives we could be saving if we kind of innovate, if we become more efficient, if we really think outside the box. So I'm looking forward to kind of digging into that.
Let's pull a thread on that a little bit.
Yeah.
You said we could do more and
Yeah.
save more lives. I agree. I gravitated to heart and lung transplant immediately because I saw the dramatic difference. No other therapy, in my opinion, that we were doing in heart surgery really gave you that impact when your patient got a new heart. It was
Right.
night and day. But there are 100,000 people on the transplant
Right.
waiting list across all end-stage organ disease. Certainly a lot of those folks are on the heart transplant waiting list. End-stage heart disease is a very debilitating condition. And we are transplanting, roughly about 4,500 to 5,000 people every year. And every year it's getting better. What do you see are the challenges, though? How could we expand that therapeutic option for people, and how and what do you identify as some of the opportunities for improvement?
Well, I mean, I think that the math on some level says it all, right? There's, as you said, maybe 4,000 or so heart transplants a year, but there's 5,000 people added to the wait list every year.
Right.
And that's a carryover of another 3,000 that stay on the list. So in total, you have about 8,000 people on the wait list. And so maybe half get transplanted. Many don't survive to transplant. And so that alone is kind of startling, right? It's sobering. But another thing that's come along is that we are using hearts now that we weren't using 10 years ago. The whole phenomenon of donation after cardiac death, basically bringing dead hearts back to life or resuscitating dead hearts, is a whole other category of donors that up until 2019 or 2020 in the United States were not really part of, our options.
Right.
And with that has come very elaborate, sophisticated techniques to be able to use those hearts. These aren't I would say very straightforward, brain dead, classic kind of organ recoveries that historically we've done for 40 years, right?
Right.
So, and with that comes a whole other level of technical demand. It's a steep learning curve. It's a very strenuous and sort of time sensitive action
Right.
where a lot of things could go wrong. So that I think is, as I alluded to at the beginning, probably this one area where it's changed the most, and there's I think even more opportunity to get better with.
So I want to talk a little bit about your healthcare executive experience,
Mhm.
and then that'll be, I think, a good segue into the real meat of our
Sure.
conversation today. So you and I met in in my hometown of New York.
Yes.
Really, actually, the very first time was actually in Long Island. So
Mhm.
at the time you were leading the heart transplant program at Northwell Health.
Yes. So, I guess in my own way as a cardiac surgeon, I've been of a startup guy.
Yeah.
So that was my first venture into that. I had the privilege of starting and leading the first heart transplant program on Long Island, which, to kind of put it in perspective, is a short driving distance by at least on a map, maybe not with traffic, but
Right.
to Manhattan. And Manhattan has, if you look at the U.S. news right now, probably four or five of the top 10 heart centers in the United States.
Correct.
So it's probably the most competitive medical environment, cardiac environment in the country, if not the world. And, really just giants in the field of heart transplant next door. But the idea of starting a program for Long Island was motivated by the fact that a large portion of the transplants done in Manhattan are on Long Island
Long Island
residents,
residents.
and needless to say, this was not a welcomed prospect by the powers that be in Manhattan. So it was certainly a high risk, high reward venture,
Sure.
meaning that it was going to be under a very high level of scrutiny,
Right.
so failure was going to be broadcast, and but I felt confident. It's really not on one individual; it's the team. So we really went to task on just building out a really solid team, and thankfully, it all worked out. It was successful, and part of that was, not trying to put it all on my shoulders, right? There's only so much an individual can do, but delegating to really skilled people. So for organ procurement for heart recovery, I delegated and outsourced that to your expert team, the STARS team, which really, as we'll discuss later, was the first sort of innovation in this concept of letting experts do the organ recovery. It was the first acknowledgement, I think, that this isn't just something you can send your most junior person on your team to do because it's pretty straightforward and all of that. It's reflective of and acknowledging the complexity, the urgency, the stakes,
Hmm.
right? So I bought into that
Yeah.
and obviously never looked back because it worked out.
Yeah.
And so, yeah, so that was as far as a physician executive, that was one of
Yeah.
my startup ventures, and
And
I think it was successful.
by
Yeah.
many measures, you absolutely were successful. So
Hmm.
you left that role, and then you went on to the great state of Texas.
Yes.
And then what did you do there?
Yeah. So that was kind of not so much a startup, but it ended up being a startup. It was more of a trying to grow a program, meaning it was, heart transplant, as I learned, is probably one of the ultimate team sports in medicine,
Correct. Yeah.
uh, from all angles, from before the patient is even thought of as a candidate for heart transplant, all the various specialties and disciplines that have to, come to the table and render their sort of assessments of someone's candidacy for transplant. But then it's to grow a program. Uh, it's not so much, yeah, just get some folks listed, and as the surgeon, I'll just transplant them.
Right.
It's actually it's the whole gamut. I had to learn uh, from recruiting to what are the elements of the team that need to be there.
Hmm.
What are the focus areas and priorities for growth? Heart failure cardiologists, right? You have to kind of it's a lot of upfront institutional investment to basically build out a team,
Hmm.
and often it's another challenge is it's often difficult to convince an administration that you have to invest in something before it happens,
Right. Yeah.
and
I
and
think any entrepreneur
yeah, yeah.
any entrepreneur,
uh,
anyone that's doing a startup could definitely attest to that. Yeah.
Yeah, so that's where it's so there was a lot of that huge learning experience. And as part of that, it was when this whole phenomenon of DCD
Hmm.
really began to take, and this concept of
That's donation after cardiac death.
donation after cardiac death.
Yeah.
And what we were noticing is that programs, from the West Coast and the Midwest were flying into Dallas or other parts of Texas, doing these resuscitations on dead hearts, and then bringing them and taking them back to where they came from.
Right.
And I was like, no one in Texas was doing it. So Texas was sort of where a lot of, you know, programs from the outside were coming in. So I was like, we should do that. I mean, that's an opportunity. We're
Sure.
not, and so I embarked on building out a team at Medical City Dallas for HCA to really be a startup in DCD for
Yeah.
Texas, and that was successful. We really planned for months at a time, and the stars aligned, and we had a local donor, so which meant we can all caravan and like
Yeah.
three different, we probably brought way too many people, an army of perfusionists and equipment and all of that, and it worked out. And then slowly but surely, one became two, became five, and then we really pioneered that in the state of Texas,
Yeah.
and very proud of that. That was 2022.
Yeah.
Unfortunately, by 2023, we almost had no wait list left because
You're
uh,
so
we,
successful.
we were we sort of were one of the few programs doing it. So it was a huge learning experience, but I think it was really an opportunity to really do the deep dive and get exposed to this exciting, fast-paced, quickly evolving area of donation after cardiac death, organ recovery.
Right.
And it's only just gotten more complicated, more sophisticated, and grown the volumes. Like you said,
Correct.
I think it's upwards of 40% now,
That's right.
almost,
Yeah.
of organ transplant.
Yeah.
And in heart, the same trend, which is really a monumental shift
That's correct.
in
Yeah.
how this space used to look 10 years ago.
Absolutely. Last couple of cases I've done, in fact, when I was in NRP, like they were so far and few between many
Yeah,
years ago, if at all. So you're absolutely
right.
right. So there's clearly a defining characteristic of your career, pioneer, leading, doing things that others haven't done. And we are actually right now in a environment here in this lab about to embark on,
Yes,
on possibly something that's never been done before, as far as I know.
right.
But it really was the culmination of your vision of seeing the opportunity to take a technology, which we both kind of collectively discovered, and create an opportunity for surgeons to become facile and also get exposure to
Yes.
these techniques
Hmm.
that are leading to increasing the donor availability of
Right.
organs, particularly hearts in this case for transplant. So tell us a little bit about that. Tell us about the culmination of this idea. And here we are in the simulation lab, and we're going to be working with our colleagues here shortly
Right.
and doing some incredible things. So let's
Yeah,
let's talk about that.
this is really exciting. So as I mentioned, the idea of using DCD hearts really just snowballed. It's become a massive demand, and so much so that we've seen the emergence of third-party companies that basically provide these procurement services, these organ recovery services, with this purported expertise, elevated expertise to be able to safely retrieve these organs.
Hmm.
And just to put it in context for maybe folks that aren't super familiar with it, as heart surgeons, right, we use the heart-lung machine, and it's part and parcel of what we do every day.
Every day, yeah.
And the idea with using these organs and this technique, NRP in particular, is the idea of someone has died essentially,
Hmm.
5 to 10 minutes before. And you are going in and going on the heart lung machine like we do in heart surgery every day. It's just done under extremis, speed and safety are paramount. A lot can go wrong, but the sooner you can reestablish flow with the heart lung machine, the better not only the heart, but all the other organs do.
Right.
So it's really about a technique that is not just centric to the heart or matters for the heart. It's really a global, the entire, any organ that's being potentially considered for recovery benefits
Hmm.
from a timely and safe execution of this technique. The problem is that in today's world, that technique, that approach, these recovery models isn't consistent.
Right.
The technology has become much more sophisticated, yet it's the sort of the we've not caught up
Experience.
the
Yeah.
experience sort of
Yeah.
on the technical side and the clinical side, the personnel side. It's really a matter of who is it that shows up, what their individual experience and is, and how do people become facile with this? What is the training paradigm? And it's really runs the gamut. It's not standardized either. There isn't
Right.
really a formalized pathway to train in this. And the idea was, if we're going to do this, if I'm going to help develop a national organ recovery system and offering, we need to standardize that. We need to elevate the standard. We need to standardize how individuals, whether they're the surgeon, whether they're the first assist, whether they're the perfusionist, whether they're the preservationist, the entire team,
Right.
we need to create a mechanism for them to train in a safe environment, in a high fidelity simulated environment. So this concept of using perfused cadavers came about.
Right.
And at Vanderbilt, we had done something similar like this for our trainees.
Right.
And I thought, well, wouldn't that be an amazing way to create an environment where we can bring in teams? We can, there's a lot of surgeons and clinicians and individuals at OPOs that want to get involved.
Right.
And again, a lot of this ad hoc apprenticeship approach, I think, is not the best way. And I think this is really going to be an exciting and impactful way to standardize training.
So kind of going from variability to reproducibility with
Right.
better outcomes, obviously,
Right.
and also spread this training across the multidisciplinary team that are involved in
Mhm.
these very high stakes cases.
Yeah. So
Well,
it's not. Yeah.
lives are on the line.
Right. It's not just about, hey, this is surgeon centric. We got to make sure the surgeons are up to. It's basically making sure the whole team gets reps
Hmm.
and you get feedback in real time,
Yeah.
and you get to so that your first experience or exposure to this isn't on the job, like
Right.
where a real heart,
Where a real
where
heart
real organs
and a real recipient on
and a
the other
real
side.
recipient is sort of on the other side.
Right.
And so I don't think that's the right way to do it.
Yeah.
And this is 2026. I mean, that shouldn't be. We should be able to come up with ways, and I think this is going to be a really effective way to provide training to standardize it, so that we make it as safe as possible. We maximize the yield of organs to save more lives.
Right.
At the end of the day, that is the most important by far.
Absolutely.
Um, but it gives individuals doing this more confidence. It would give hospitals and implanting centers more confidence, and at the end of the day, save more lives.
Yeah.
Right. So,
Outstanding. And if you think about this is today, I mean, this is, one of our very first
mhm.
ventures into doing this. Very exciting. We have a team of folks to helping us out to bring this experience to some surgeons. We had to paint a picture, broad strokes of your vision of what you think this type of concept and maybe others like them down the line would be. What would you envision?
Yeah, well, I mean, the beauty of this is this isn't well, we can only do it in this city at this
Right.
time. We could reproduce this at scale
Hmm.
and do it all over the country. We could do it in such a way that it would cater to maybe concentrations of individuals, maybe for OPOs if they want a training for their clinical team. Um, I would love for this to be a mechanism for certification,
Right.
where like so many other things we do in medicine, there's a process. ACLS,
Right.
BLS,
Yeah.
trauma certification, board
Yeah.
certification. Yet for something as vital,
Consequential.
consequential as organ recovery to save lives, it's sort of loosey goosey. It's kind of all over the place, really. There's not any standard way for certification. There's
Hmm.
like you have a case log. Basically, you show somebody, yeah, someone signs off, and then there's no objective mechanism to really make sure people are safe, that teams work well together. There's
Right.
always room for improvement, right?
Absolutely.
So I envision this as becoming kind of the standard approach for training people in the not only organ recovery space, but this could extend into other potentially facets of surgical training,
Right.
um,
And other disciplines
other
potentially. Yeah.
disciplines. Absolutely.
Yeah.
So, yeah, I think sky's the limit for this.
Yeah. Well, testament to your vision, your innovative
Thanks.
mind, and certainly your ability to see how things can come together. And of course, I can't help, and I'd be remiss if I didn't say this is a smarter healthcare with AI
Hmm.
podcast. So, where do you see technology and AI in particular sort of having a play in this whole milieu of everything you just described, which is the standardization, giving people the simulated real life experience
Sure.
of what they would, actually encounter in sort of a real life scenario, but do it in a safe environment. Where do you see, this is a bit of a teaser, of course, because I know some of the things
Yeah.
that we're going to be, utilizing for this training. But yeah, tell our audience, like, what are some of the really, novel and unique things that, will be incorporated in this type of training?
Well, I think there's a huge opportunity for involving AI and machine learning into the organ recovery process, particularly when it comes to NRP and perfusing, right? A huge area of interest of mine in research is goal-directed perfusion, which is basically when we use the heart-lung machine for heart surgery. It's not just turning the machine on and just forgetting about it. It's this idea of actively managing and making sure you're getting enough oxygen to the patient.
Hmm.
And there's a lot of AI that could be used to sort of figure out in real time, hey, is this patient getting enough oxygen on the heart lung machine at this
Right.
particular time?
Yeah.
Um, Similarly, that concept, that framework could be applied to organ recovery. During NRP, we could be basically determining uh, for that donor, are these organs getting enough oxygen right now?
Yeah.
Is there anything we could be doing while we're in this resuscitation phase
Yeah.
that could maximize the likelihood, right, that these organs are gonna really thrive, that they're just gonna
Yeah.
uh,
Because what's being done now?
it's totally, well, you just put them, turn the heart lung machine on and, stay on for a while, wait for the heart to wake up and just kind of
Yeah.
check a couple
Yeah.
labs.
So it's
Oh,
really, synthesizing data to make a better decision and get a better
yes.
assessment of what's
Right.
happening.
I think invoking AI for risk prognostication,
Hmm.
predictive analytics, uh, the vital signs that donors have during the withdrawal phase. There's so much rich data there that could be used to help determine, how's this heart going to do, or is this someone whose organs are going to need a little bit more TLC? Do we need to
Hmm.
really be thinking about on the recipient side also completely a black box as far as how the heart lung machine is managed on the recipient side? And we've shown now recently that how you manage that aspect can actually overcome a lot of the warm ischemic damage that organs undergo during the recovery of the
Right.
organ,
Right.
that you can actually maybe salvage and undo some of that back home when you while you're sewing that organ in. How you manage the heart lung machine could actually be used in such a way that you salvage some of that.
Yeah.
This is completely understudied
Yeah.
and obviously a perfect use case for AI.
Yeah. Very cool. And we're going to be using some physical AI too, right? How would you describe that to our audience? The cameras, the visualizations, and some of those very novel technologies that, as you know, computer vision and other things like that can be
Hmm.
used to enhance our simulation, but also the application of how we approach these techniques in these scenarios.
Right. So, I mean, there's all sorts of things about how do we know a heart, as in one example, looks good. It's sort of
It's kind of a gestalt. We
it's a
learn.
gestalt. We look
We
at,
know. We've seen
we,
hundreds of them.
right. We every on every heart recovery, there's the sort of you take the video,
Mhm.
someone holds a camera, the shaking camera with bad lighting over, and you see the heart beating from afar, and you have someone on the recipient side at 2 in the morning saying, "Yeah, yeah, sure," with one eye half open, that looks okay. Uh, that's it,
Mm.
right? Maybe some vital signs, but maybe having sophisticated imaging,
Mhm.
right,
Mhm.
where perhaps over thousands of hours of looking at things
Right.
like that,
Right.
our technology would be able to tell us, well,
Yeah.
after seeing a million of these,
Right.
maybe this heart needs a little bit more time, or
Yeah.
be on the lookout for XYZ, or be
Sure.
concerned about this and that. Totally understudied, unknown. It's sort of this is how we've always done it, so
Right.
this is how we'll continue to do it
Yeah.
mindset, which I'm totally not happy with, right?
Right.
So
Yeah. Well, I so we'll be using some other AI novelties. I have my little ambient technology here that we'll be recording our session because AI is so ubiquitous now and it's being used in various capacities. But we and you have mentioned that organ recovery and dare I say all of transplantation is a very team intensive
yes,
enterprise,
yeah,
right? So we are the surgeons, but we're one piece of a larger, sort of pie, if you
right.
will, of all of the different components that can come together. And this training simulation, of course, but all the other things that we're sort of incorporating in this kind of environmental training and simulation will come to bear. How do you see enhancing team performance around this simulation exercise right now and endeavor, but also in using AI to sort of enhance some of those communications, some of those interactions between the teams?
No, I think there's especially when you think about how things are done now, where there's these moments where there's sort of a radio silence during
Mm,
these cases,
yeah.
where the organ
And
recovery.
just to unpack that a little bit for our audience, because you and I know what we're talking about. What radio silence means, like the recipient side,
Yeah,
there's a whole team waiting.
yeah,
Is the organ good? Are we going to
right.
take it? But
So
on our side, on the donor side, we're
right,
working, right? So you can't physically pick up the phone and call,
yeah. So there's
and
this
and there's this angst.
there's all these moments throughout this process where if you're on the recipient and you're at the recipient hospital, you're fielding 20 text messages about, hey, what's going on with the donor?
Mm,
Where's the donor? Did they go to the OR yet?
right.
How's the donor doing? Okay. When's the donor coming?
Yeah. Yeah.
When should we roll with the recipient?
Right.
And this is every time.
And it's all this coordination that has to go
Right.
on. Yeah.
And then, but the donor, team they're in it. They're in the
They're in
thick
it.
of
They're
it.
busy.
They're scrubbed in. We can't be, unscrubbing to get a phone and make a call. And so that communication process is less far from ideal.
I'm
Yeah.
laughing. I got to interject a story here, which will give us
Yeah.
a little perspective for dating us. But I had a young man who was asking us about, how do we do this work in transplant, and you and I remember decades ago before we could actually take video and send it over, we were calling literally and trying to describe just verbally what we were seeing and hope that the person on the other side, the recipient team, is going to say, okay, well, I trust Dr. Lima, I trust Dr. Teta. And that was all the data they really
Yeah.
had. It was and the young man, he said, why don't you just take a picture or a video and send it? And
Right.
so I said, well, I had always envisioned that that would be the case. And
Sure.
then boom, we had a technology that was able to give us that
Hmm.
opportunity. But what you're talking about is something even more high fidelity and more real time.
Absolutely. No, I mean, I think there's we've come far too long to not be able to capture all this in real time
Hmm.
for everyone involved.
Right.
There should be no reason that these periods of radio silence should exist,
Hmm.
right? There's got to be workarounds for these things.
Hmm.
There's got to be ways where if you're on the recipient side, you can say, "I wonder how things are going over there," and
And no,
literally
dynamically.
and just patch in and be
Yeah.
like, "Oh, okay, I can see what they see in
Hmm.
real time."
Hmm.
Whether it's what's happening on the heart lung machine, what's happening visually, what's everything, right?
Yeah.
Again, because this is such a mission critical uh, I think
where every second counts.
every second counts. We Things happen so quickly, particularly in DCD, right, where you don't know exactly when a donor may expire, may progress. It could happen it's super unpredictable. It could be very stable, and all of a sudden, in a matter of 2 minutes, you're off to the races, and you have to get in there and all that. So often on the recipient side, we're just sitting there wondering,
Right.
right? We can't call anybody because everyone's very frenetically getting,
Busy and doing
busy getting
things.
things going, trying to bring that heart back, right?
Right.
So that there's so much room for improvement in
There's so
that.
much room. Yeah.
Absolutely.
Yeah. And you're leading that effort. Absolutely leading that effort.
Trying to. I think one thing is acknowledging, right, that things should be better, and
Yeah.
then being committed to doing something about it.
Yeah.
I think, and that's why I'm passionate about this initiative, about helping create this new paradigm for organ recovery.
Right.
I think there's a inordinate amount of focus uh, for a lot of those involved in this space to just get the next case done,
Yeah.
and that in of itself also is very unorganized, and should be standardized, and should be regionalized, and should be thought about in a more strategic, efficient way,
Hmm.
because there's a whole other dimension of uh, excessive cost where there doesn't need to be,
Right.
right? And that matters.
Right.
We are talking about obviously patients and getting recipients more life-saving organs, but there's a whole world of how this is being carried out today that's wholly inefficient
Yeah.
in many respects, and really needs to be kind of completely overhauled in
Yeah.
many respects.
Well, I am proud to know you. I know and have, I know that you're on the innovative cusp of all of this, and that this is just the beginning of more to come in
Hopefully.
terms of
Yeah.
enhancing our opportunities to recover organs and do that with the fidelity and the standardization and optimization that we're all seeking through this simulation lab. That's going to be an incredible experience for everyone. And in closing, you are an innovator. You are certainly one that has, gone into new, uncharted territories and been successful. And this is just one of another one of those chapters. And it's very exciting to see where this is going to go. You think about the future of heart transplant, and there's so many things, right? I can't help but wonder and think that there are so many things on the horizon that we are not even privy to yet, and we've seen. I remember being a student and my senior professors telling me, we'll never see xenotransplantation, but we
Sure.
know one of our colleagues has done that for the heart. And there are all of these different technologies, artificial heart,
Hmm.
and so forth. I think transplant will always be here to stay
Right.
for the foreseeable future. Um, we just had an Artemis mission in space, right?
Yeah.
How is that going to, play into this role of what we're doing here? How are they going to, diagnose heart disease in space without MRIs and CAT scans and maybe echoes and things like that?
Right.
So, are you optimistic about the future, and
Oh yeah.
where do you see us, going with all of this?
Well, I think, as you said, there's many fronts on this battlefield. There's the space that we're in now. Transplant.
Hmm.
As many advances that have occurred over the last, in recent, number of years, there's still much more room for improvement. And I
Right.
think increasing the yield of life-saving hearts
Hmm.
is still very much a major path that will yield fruit. But to your point, yes, there's continued vigorous efforts on the xeno transplant front. Obviously, artificial heart is something that continues to evolve and advance. And I think w- the big breakthrough, obviously, that everyone talks about is the moment that they can become wireless,
Right.
right? And so when battery technology catches up, where we can actually power something like an artificial heart that delivers, 5 liters a minute of flow continuously, right? To sustain a human life. As right now, the model for that is someone still remains somewhat tethered to a battery. Uh, the moment that that's no longer necessary, that'll be a tremendous breakthrough. And then, of course, the idea of growing organs, right? Stem cell technology, things like that. So whatever the future, holds, it's going to be exciting because I think significant headway is being made on all of those fronts.
Yeah.
So
Wow. Well, that is powerful, powerful, exciting,
thank you.
and certainly an enthusiastic way to close our session. And it has been an incredible honor to visit with you and to learn about
Thanks for having me.
your
Appreciate that.
incredible journey and your leadership in this innovative space of not only heart and lung transplant surgery, but all of healthcare, because we only scratched the surface. And I would encourage our viewers and our audience in Smarter Healthcare to just come to learn a little bit more about Dr. Brian Lima. He is an incredible pioneer at cardiac surgery. He is a healthcare executive, and more importantly, he's an innovator, one that's going to be leading the future of healthcare, cardiac surgery, and medicine for many, many years to come. So thank you so much.
Appreciate it. Thank you so much. All right. Great to see you.
Looking forward to our session here and doing something very novel. All right. Thank you for this episode of Smarter Healthcare with AI. Join us next time when we'll have more guests that are leading in the space of healthcare innovation and AI.
This has been Smarter Healthcare with AI. If you'd like to find out how to bridge the gap between medical experts and tech innovators and discover how AI can make us healthier and more human, go to Tetteh.com. Smarter Healthcare with AI with Dr. Hassan Tetteh is a production of Forbes Books.